Welcome back. I assume you have already listened to my previous presentation summarizing this trial of mailed feedback to primary care physicians on antibiotic prescribing for patients 65 years and older, pragmatic factorial randomized controlled trial. I am Kevin Schwartz. I'm an infectious disease doctor at St. Joseph's Health Centre at Unity Health Toronto, Public Health Ontario, and the University of Toronto. I'm now going to take you through the curriculum wheel for pragmatic randomized controlled trials, specifically about this recently published trial that is in BMJ and available there at that link. So to go through the curriculum reel, we'll start with the intent and question of this work. So we had 9,000 active family doctors approximately in Ontario, and there was about 4,000 who are already signed up for my practice reports, which includes audit and feedback on a number of metrics in Ontario, including antibiotics. We know from previous work that the highest antibiotic prescribers do not volunteer for this feedback reporting, and we really wanted to come up with a way to engage these doctors more in audit and feedback and test to see if it was effective. So really the primary question and intent was, is mailed antibiotic feedback effective? We embedded sub-questions of, can we improve on the way that we do audit and feedback as well, to try and see if we could move this field forward in a variety of ways by changing the way that we do feedback report in a systematic fashion. So to do that, the trial design was a pragmatic randomized controlled trial in a 4-to-1 ratio. We embedded within the primary question a 2-by-2 factorial trial where we had two different versions of a letter. Sorry, four different versions of a letter, and doctors would receive either both factors. They would receive only one factor, only factor one, only factor two, or neither factors within the intervention group. A factorial trial is an efficient way to analyze data, and so that's really the main driver for why you would pick a factorial trial when trying to look at multiple questions at once, or variations of an intervention arm. One of the caveats or the important consideration is no hypothesized interaction between the different factors. They should work by likely different mechanisms. I put the link in there for the consort extension for factorial trials. This was just published last year, and if you are working on a factorial trial or considering a factorial trial, this is a really important document to go through and sort of summarizes the important components of the factorial trial and really what you need to include in any publication or submission. So in terms of implementation and impact, we really wanted something that was going to be scalable. We wanted to use routinely collected data to really make it feasible to continue to do this sort of intervention operationally. And we wanted to immediately translate this into policy. So we wanted to do the trial, and then if it works, continue to be able to operationalize this activity. And this is essentially what we've now done after showing this is effective. We've also embedded a process evaluation there. For those interested in the topic, this has been recently published, and I put the citation and link there for people that are interested. So in terms of statistics, some consideration. So we did a modified intention to treat analysis. The reason it's modified is that we did exclude 1% of the outliers after randomization for some data quality issues, but otherwise 99% was analyzed as randomized. We did a Poisson regression model that is offset by the log of the patient visits to control for the physician's patient volume, and in the model adjusted for a number of factors, including the log of the baseline antibiotic prescribing rate, the physician's sex, years in practice, as well as the stratification variable as we stratified randomization, whether or not they were enrolled in a previous trial. Um, I would say the using these adjustment features are a little bit controversial. It depends on the statistician, but it can increase the sort of efficiency and power of the analysis. And this is why our statistician likes to do that, even though it's a randomized trial of incorporating some features of the physicians we know are associated with antibiotic prescribing. We pre-specified a number of stratified analyses to look to see if the intervention effects are consistent across groups. And then we added terms for the presence or absence of each factor in the factorial analysis. It's again just some factorial analysis consideration. There are different approaches to this. So I mentioned that there should be no hypothesized interaction. So what some people do is that they actually test this after they have their data. Our statistician would generally advise against this for the reason that if you're doing this two-stage analysis after the fact, you risk increasing type 1 error. And so we really just pre-specified this and then did the analysis anyways. We did test for the interaction after the fact. And actually, we did find some interaction in the opposite direction we would have thought. But then we ended up going on and doing a couple of sensitivity analyses, analyzing the data in different ways, including as a non-factorial trial, and overall found pretty consistent results despite that unexpected identified interaction. But these are some of the additional analyses that can be done, and some of this is highlighted and explained in that consort statement. In terms of ethics, consent, and regulations. So we did have ethics approval by Women's College Hospital and Public Health Ontario. Both ethics board approved an opt-out consent process, which is really important for this kind of large-scale trial. It would be impractical and actually be more burdensome, arguably, to the physicians to try and get consent than to just give them the single mailed intervention. But we did a mailed introductory letter and gave everyone an opportunity to opt out of the trial. I put a link there for the TCPS2 criteria for a waiver of consent. There's a number of criteria, 4 or 5 criteria that you need to meet for a waiver of consent for clinical research. And again, for the ethics applications and rationale, it's really important to sort of follow that and make sure you meet those criteria, which this trial certainly did. In terms of trial materials, I sort of just refer to the study and the appendix. In terms of the actual intervention that we did, I did show briefly in the previous presentation, and those are all available online for those interested. Partnerships and support is really important. And so this is our infographic we use for presentations. It shows all the different partners that we have in this grant. So this is CIHR funded, but there are a variety of partners. And actually, this is part of a CIHR SPORE grant where you need matching funding. So a lot of these partners provided either in-kind or direct cash contributions to the funding of the grant. So these are all funding partners, but also just collaborators, institutions from different researchers, but you need a lot of partners in different sectors to be able to do this kind of intervention and trial. I wouldn't say we have any specific Indigenous rights or data sovereignty learnings from this trial. We did not analyze the data based on Indigenous groups and no specific engagement for the purposes of this grant. For quality control and oversight, I would sort of highlight that there's built-in quality control with our administrative data sets in Ontario. That's through ICES. And this is routinely collected data that has those built-in controls, which is quite an advantage, I think, for the conduct of this trial. Which leads into the collection of data. I was just going to highlight the process that we need to do, but there was no primary data collection. We used only routinely collected administrative data. There's a bit of a process involved in that. The Ontario Drug Benefit, which is highly accurate for patients 65 and older for drug information. We also use the Ontario Health Insurance Plan and link to other administrative databases. We needed then the physician numbers are anonymized in our administrative data, so we needed to have a process to de-anonymize the CPSO numbers, which we can do, and then share with Public Health Ontario, who is conducting the intervention. We then link to a CPSO database with approval from CPSO to get the physician's names and addresses linked to their actual prescribing data. We then send out the opt-out letter through a third-party printing company. We then create the data file with individual image files, and then we randomize the physicians and then share that data and the image files with the printing company. They do a mail merge to make individualized letters and then send that out to the physicians. We then have to link the randomization list, the randomization groupings back to ICS, and then we did all the analysis within the ICS infrastructure. Inclusion, diversity, equity, and accessibility. I think the comments I just wanted to make for this part was really about our team. I think we had a really good team of researchers and partners that are in different career stages, different genders, and had a really good input from across the board. That includes patient partners as well terms of financing. And so I don't have exact numbers. I tried to estimate for you, but I estimate that the actual conduct of the trial probably cost around $500,000 for, $80,000 in analyst time to pull the data and do the analysis of the trial, probably $100,000 in printing and mailing, but that includes all the qualitative work we did around it. So we also mailed questionnaires and had qualitative components that significantly increase the cost of mailing and printing. And then there's personnel to run the trial, project managers, postdoctoral students. So I'm not sure exactly, but I estimated $300,000 over 2 to 3 years for personnel to conduct the trial. But overall, this is a relatively cheap, large clinical trial. What I do want to highlight is that we have a cost effectiveness analysis coming out as well, but that we're operationalizing this work. So we're doing this now this year, the same intervention, not as a trial, and it probably costs around $40,000 to conduct the intervention. And this is a highly cost-saving intervention. And so it is not an expensive thing to do. And really part of the rationale of how we did it, we wanted something that is scalable and something that we could operationalize within the public health system and healthcare system. And that's the end of the wheel. Thank you so much for your attention and interest in this trial.